All right, so let's start by doing some gross anatomy of the urinary system. Okay, so they are going to involve the kidneys and the ureters, which are the tubes that go from kidney down to urinary bladder. Okay, you have two of those, two ureters, two kidneys. And then you have the urinary bladder, and then the urethra. Okay, so those will be some of the main parts we'll focus on today. Also, don't confuse ureters with urethra. In a way, they kind of sound similar, they look similar in spelling, but they are different. Okay, ureters go from the kidney to the urinary bladder, and the urethra goes from the bladder to the external environment. Okay, here's a posterior view, a little less busy. Okay, so you have left and right kidney. Okay, they are protected by the ribs. Okay, there's the ureter on both sides, urinary bladder, and the urethra. Okay, the urinary tract is considered the ureters, urinary bladder, and urethra. Okay, so if you have a UTI, urinary tract infection, you're usually referring to the structures between or the ureters, urinary bladder, urethra. Okay. Once the kidneys are infected, it's a little bit different story. Okay. And in patho, we'll get into more of pre-renal and then intrarenal and then post-renal infections. But for now, just know that when you think urinary tract infection, ureter, urinary bladder, or urethra. Okay, the functions. Okay, so structure and function, right? Another way of saying that is anatomy and physiology. So some of the functions of our urinary system is the storage and excretion of urine, the regulation of blood volume, regulation of erythrocyte production, and acid-base balances. Okay, the kidneys are really good at, well, there's some other things we can throw in here. Okay, filtration. And the way I like to say it is you keep the good stuff and you get rid of the bad. Okay. So with the kidneys, kind of an easy, quick way of looking at it is you keep the good stuff and you get rid of the bad. And we'll talk more about that in a little bit. Okay. Erythrocytes, those are your red blood cells. And it does this through that EPO, erythropoietin. Okay, the kidneys does help filter things out, keep the good stuff, keep the bad stuff. Okay, ureters allow for fluid to be transported from the kidneys to the urinary bladder. And the urinary bladder is a temporary storage tank of the fluid that we call urine. And then the urethra allows the urine to be expelled to the outside environment. Okay, so in lay terms, you pee. In fancier terms, micturate or void. Okay, here's a section of you in the transverse plane. Okay, just showing you there's the left and the right kidney. Okay, so if we order MRIs, then typically MRIs really like to look at the transverse plane like you're seeing here, and also the coronal plane, which is looking at slices of a person from the front view. So this would be an example of a coronal view. So you take a kidney, cut it in half, and you're looking at it anterior to posterior. Okay, so once we get inside the kidneys, some more anatomy parts to know. Okay, you have the renal cortex. Okay, so that's the outer layer of kidney. Now, keep in mind, anytime you see the word cortex, that really just means the outer part. And then the medulla means the inner part. Okay, then you would apply that to whatever it is you're looking at. For example, the cerebral cortex, that's the outer part of the brain. The medulla is the inner part of the brain, like bone. The cortical margin or the cortex of bone is the outer part of bone. The medullary cavity of bone is that inside part of bone where you find the bone marrow. Okay, so really anything in the body that has cortex and medulla, it's just letting you know it's the outer part of whatever it is and the inner part of. Okay, so the kidney has its outer part, the renal cortex, and the inner part, the renal medulla. Okay, so you're seeing the outer cortex. It's like basically all this part here in the kidney, and it does have a function, which we'll talk about in a little bit. Okay, and then you have the inner medulla, okay, which is like all of this part. And that also has a function that we'll talk about in a little bit. All right, so cortex, medulla, then you have renal pyramids, okay, because they're kind of shaped like a pyramid. Okay, so you have a bunch of renal pyramids. And then what separates the pyramids are the renal columns. Okay, so there's a column, there's a column. Okay. Then you have the calyx. Okay, you have the calyces, so plural would be calyces. So the renal pyramid, if you kind of look closely, I'm going to draw it up here. Okay, they kind of point to a middle, an inner part. So they all point in a certain direction. Okay, ultimately what they're pointing to is to try to get fluid to go down the ureter. So the pyramids are pointing or taper into these calyces that you can see right there. Okay, it's like a little funnel. Okay, they call that the renal calyx. Okay, then after the calyx, the big part is called the renal pelvis, which is all of this. And the pelvis is kind of your, back to your funnel analogy. Okay, so as fluid is coming in, it's going to funnel it down the ureter. So ultimately, they're coming from the calyces into the pelvis and then down the ureter. Okay. All right, blood supply. You do have the renal artery, which brings blood into the kidney. Very important. And the renal vein, which will allow blood to leave. Okay, arteries send blood to the body. Veins return blood back to the heart. Okay, another function of kidney is blood pressure. Okay, so blood pressure is, I mean, there's a lot of things that can cause and contribute to our blood pressure or hypertension or hypotension. Obviously, lots and lots of things. But kidney is one of them. Okay, so if a person has blood pressure issues, one of the things to put on your differential diagnosis list is kidneys. Okay, now granted, the kidneys could be spared, they could be fine, and something else is causing high blood pressure, like the blood is too thick, right? The viscosity of blood, okay, or the person's tubes. Remember your arteries, they're not really nice and open, but rather they're really small. So really small tubes increase peripheral resistance or increase blood pressure. Okay. And on we could go with blood pressure issues, right? But kidneys can be one of them. So as part of a differential diagnosis, you want to think kidney. Rule it in, rule it out. Okay, then you have the ureter. And that's where the fluid or the urine will be stored into the urinary bladder. Okay, once you get inside the kidney, you've got some very, very functional and really a very important part. Okay, and that is the nephron. Okay, the nephron, you can kind of quickly associate that with a site for filtration, keeping the good stuff, getting rid of the bad stuff. Okay, now what this diagram is showing you, it's just zooming in really tight to how fluid enters into the kidney. Okay. So we'll sort of be talking about some of this as we talk about the nephron and the glomerulus and all that stuff. Okay, so when you take the nephron and you zoom into it, right, the components to know as far as gross anatomy, you have the renal corpuscle. Okay, and the renal corpuscle is made of Bowman's capsule, and the glomerulus. Okay. So one way you can look at Bowman's capsule is um, as an analogy, kind of like a baseball. So if you look at a baseball, right, the outer skin of the baseball is leather. And when you peel away that leather on the inside, it's actually just a big knot, big ball of yarn that's woven. Okay, kind of like the the renal corpuscle. You have the outer skin, which is Bowman's capsule, and then you have the inner ball of yarn, that's the glomerulus. But instead of yarn, it's capillaries. Okay, very specialized type of capillaries. All right, and then you have um, now going in order here. Okay, so we're going in order from beginning to end. In other words, if you're fluid, you're entering into this area in a certain order. So as fluid is coming in, it's going to go into the glomerulus. Okay, and later we're going to talk about the GFR, which stands for glomerular filtration rate. Very important. Okay, so as fluid is going through and it gets through the glomerulus, which is right there, the next thing it's going to come to is the PCT. And that stands for proximal convoluted tubule. Okay, the proximal convoluted tubule. Okay, it gets its name because it is the most proximal or nearest to the glomerulus. It's convoluted, which means it's all kind of twisted, and it's a tube, right? So the PCT, the proximal convoluted tubule. Okay, then after that, still going in order, you have loop of Henle, also known as the nephron loop. Okay, the loop of Henle or the nephron loop. Okay, now as we're traveling back up, then you eventually come to the distal convoluted tubule, which is all this stuff. Okay, the distal convoluted tubule, and it gets its name because it's farther away from the glomerulus, therefore distal. Okay, so simply put, you have a tube that comes in. I'm going to do it this way. A tube that comes in, hits that glomerulus. Okay. Then you have the proximal convoluted tubule, then the loop of Henle, okay, and then the distal convoluted tubule. Okay, so fluid comes in, goes to the glomerulus, then goes to the proximal convoluted tubule, then goes down and then up, loop of Henle, then eventually gets to the distal convoluted tubule, then eventually will spill into what's called the collecting duct. Okay, and then from the collecting duct into um, uh, the ureters, and then eventually into the urinary bladder. Okay. All right. Okay, so blood supply, or the arteries, is a very important functional part to kidney health. Okay, so in other words, circulation. Okay, so incoming fluid they call afferent arterioles. Okay, so anytime you're coming into the kidney, that's afferent. All right, when you're leaving the kidney, that would be efferent. Okay, so once blood exits the glomerulus and the renal corpuscle, now we're dealing with efferent vessels. Okay, don't worry about that one. Okay, so nerves, okay, called the renal plexus, enters the kidney at the hilum. Okay, so the hilum, or hilus, are all the tubes that come in and out of like this area of the kidney. Okay, so a lot of tubes that and wires that come in and out of that part of the kidney, and that's called the hilum. You may also read it as hilus. Okay, so the sensory fibers come from the dermatomes from T10 to T12. Okay, so in my particular world, I do a lot of spine work, skeletal, and of course all the muscles and then joints that go with it. Now, as a result of dealing with the skeletal system, especially the spine, you're also tapping into the nervous system. Okay. So there's a lot of research and evidence and things like that, case studies out there that do show that if your vertebra, so it'd be L5, there's L4, L3, L2, L1, T12, T11, 10, and so on. Okay. So a lot of evidence out there that shows that if you mess up the vertebra, right, and there's the nerve roots that come out of your spine. Okay, you mess with the vertebra, you mess with the joint, you mess with the disc, you can mess with the nerve root. Okay, and the nerve root branches and innervates a ton of stuff within its area. And so a person can come in, and I see this a lot, with a messed up spine right there. And that would be their primary dysfunction, but it's causing a secondary dysfunction, kidney. Okay. So once we improve the nervous system via influence on the bones, the joints, the muscles, you actually do improve the nervous system. And then what happens is function goes back up. Now think about that. And this concept applies to everything in your body, what I'm about to draw here. So we're going to pick on kidney at the moment, but this applies to everything. So here's a nerve. Okay, now think about this. If you cut the nerve to that organ, what happens to the organ? Okay, it dies. All right. If you infringe upon it by creating some sort of pressure, like a herniation, a disc bulge, disc degeneration, okay, or any kind of joint dysfunction, muscle tightness, muscle spasm, and so forth. So now you're just infringing on it. What happens to function? Well, it goes down a little bit. And as time goes by, it goes down a bit more. And then the function goes down. And now the kidney starts to become symptomatic. So you have signs and symptoms of some kidney issues. Okay, now by this time, it's sending signals to the brain that something's not right. Okay. So this is an area that does happen to people. In other words, for all intensive purposes, their organ is fine, but the reason why at this point it's not fine is because the nerve has been infringed upon. So if you can improve the nervous system, right? In this case, it's the sensory and autonomic fibers called the renal plexus, and you can get pain because of the nerves that come off the dermatomes T10 through T12. So in other words, the body's letting you know your kidney's pissed because your nervous system is pissed. Because between T12 and L2 is being infringed upon. Okay, and I see this quite a bit because now we're getting into low back area. Plus this is a junction. Once you go from T12 to L1, okay, that's the thoracolumbar junction, which means it's a very common area to be infringed. Okay, for the vertebra to be infringed, which then infringes on the nerve roots. And then you have to trace where the nerve roots go, and now you can figure out what organs and tissue is not going to be behaving right. Okay, so a little more specific look at the glomerulus, right? So there's the knot of capillaries there, the glomerulus. Okay, proximal convoluted tubule, loop of Henle, distal convoluted tubule. Okay, we'll talk about what they do in just a minute. Okay, the nephron is the main filtration part of the kidney. So that's what makes this very important. Okay, so one way in our culture that people hurt their nephrons is NSAIDs. Okay, so keep in mind NSAIDs will hurt the kidney, and acetaminophen or Tylenol can hurt the liver. There is a time and a place for NSAIDs, but you do have to be careful as you instruct your patients and monitor them, and advise them and stuff like that. That like for example, you catch someone, man, you've been taking 3,000 milligrams of ibuprofen a day for like the past couple of months. You're on your way to hurting your kidneys and your stomach, okay? Because those are some of the side effects of NSAIDs, right? So um, I do think it's important to at least make them aware that they're getting into very dangerous territory, okay? Now, obviously, there's other things that can hurt the kidneys, but in our culture, that is one of them is side effects of medication. Okay. Um, all right. So to zoom in a little bit tighter to the tubes, okay, here's what I want you to think as a quick version. The proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule are there to help keep the good stuff and get rid of the bad stuff. Okay, that's just a quick version of how to think about this. With all the convoluted things that you see, okay, that just looks like a big twisty mess. But really what that is, it's to increase surface area to allow for maximal absorption or reabsorption and getting rid of things, okay? So you're going to keep the good, rid of the bad, all right? And in all of these tubes, you want them to be, in a way, kind of as long as possible. So instead of just being one long tube that extends forever, it's all twisted together, right? So that's your convolutions. Okay, so blood and fluid and all that is coming in. And as it's moving through these tubes, the body is going to be given time to absorb things or get rid of things. Okay, the movement of substances. Movement of substances. Okay, so eventually the movement of fluid through all of these tubes is going to produce urine. So to make urine, you have to go through filtration, reabsorption, and secretion. Okay, so filtering, very simply put, means keeping good stuff, getting rid of bad stuff. In fancier terms, reabsorbing, secreting. Okay, reabsorption is keep, secreting is getting rid of the bad stuff. Okay, your kidneys filter your entire plasma, blood volume stuff about 60 times a day. Okay, so that's a lot of energy, a lot of work that your kidneys are going through. So as a very simple, let's just say naturopathic approach to kidney care, okay, or you can also say preventative care or trying to create a healthy kidney, what you want to try to do is consume plenty of water. Okay, you want to keep your body hydrated. You want to keep the kidneys happy by allowing good amount of fluid to be pushed through the system in a good way. In other words, dehydration is in the long run not good. Okay. Bad fluids, I'm just using simple terms here, bad fluids like soft drinks and alcohol in the long run is also not going to be good for the kidneys. Okay, and yes, you're going to see patients like this if you haven't already. I do co-managing with these patients where, you sit down with them and you analyze their diet, you analyze their fluid consumption, and you realize they're very acidic. Okay, now keep in mind the kidneys do help you with acid-base balances. So the kidneys are one of many systems that help you with um, controlling that. You don't want to be too acidic in your body. Okay, so a lot of this has to do what people are consuming. Okay, simply put, they are in general consuming things that are harmful to the kidneys and not really consuming things that are good for them. Okay, so what we're trying to do is switch that. Okay, we're trying to reduce the amount of alcohol that they consume, reduce the amount of um, just non-good fluids. Like I worked with a person that was drinking about 15 to 20 diet soft drinks a day. And then what they were doing is they were putting this thing called goody powder inside the soft drink. Now, goody powder is basically taking like an aspirin and crushing it up into powder form, and then you can put that powder into any fluid and then drink it. So instead of consuming a capsule, right? So in general, when we take medication, it comes in pill form. So you just put the pill in your mouth and you swallow it. Well, the goody powder, they took the pill and they crushed it up. And so this person would take these diet soft drinks, take the goody powder, put it in each one, so 15 to 20 of these a day, and drink them. I'm like, and they've been doing this for a long time, like and now they're having significant health issues. Okay, and so when I got them, it's like, okay, we've got to start to wean you off of this, and so on. I mean, there's more to their story than that. There's other things, like for example, they were a chronic smoker, like several packs a day. I mean, just really taking their body in an unhealthy direction. Okay, now if a person does that, eventually they're going to end up in the hospital and you are going to be taking care of them. Okay, whether it's on dialysis, whether they're on a respirator because their lungs are shot, whether they're constantly fighting infections, from urinary tract infections to kidney infections to systemic disease, whatever. Okay. And a lot of this, when you look at their history, you'll find with a lot of it is the perfect storm, how they treated their body growing up and throughout their lifetime, mixed with a little bit of genetics, mixed with um, epigenetics, right? So those are kind of the usual suspects. How you treat your body, genetics, epigenetics, okay? So how you treat your body is environmental, meaning a lot of that stuff you can control. You don't have to smoke. You don't have to consume bad things, right? You can choose to exercise or choose not to exercise. So those are things that we can control, but there's some things we cannot control, and those are certain environmental pollutants that can hurt us and genetics, right? So sometimes people are just unfortunately exposed to things that they had no idea they were being exposed to. And those are toxins, like, for example, drinking, let's say, city water that happened to be tainted, like you didn't know, okay? But it hurts you in the long run. Um, so it's usually going to be a combination of that lifestyle, what they've done and not done to themselves throughout a lifetime, genetics, epigenetics, and you'll see them. And then you're going to do the best you can to try to help them. Okay. More advanced stuff would be like a kidney transplant. Okay. Their kidney is so diseased and it's so bad that you have to do a transplant. A step before that would be a renal dialysis. step before that would be just all these kidney infections, so they're constantly on antibiotics, right? And then on we could do this dance with um, what happens when kidneys stop working. Okay, so uh, because the kidneys do spend a lot of energy and a lot of time filtering out your body, trying to purify you, one way that you can help your kidneys is simply by trying to put things inside of you that are actually good, okay, as good as possible. All right, zooming in a little bit tighter into the um, to Bowman's capsule, also known as the glomerular capsule. Right, you're going to find these things called podocytes. All right, and those are the little holes that you see there. Okay, so if you look at a strainer or a colander, right, they have holes in them. And typically we take our spaghetti from your kitchen pot and you pour it into the colander, and the fluid and all that stuff will kind of leak out of the colander, and it's going to keep the good stuff. Those little holes, okay, we'll call podocytes. So the glomerulus has its version of filtering holes called podocytes. Okay, some components within the juxtaglomerular area. Okay, so this is the juxtaglomerular apparatus. So in other words, all the different, or some of the components um, that are near or within the glomerular area. It's going to be the granular cells. Okay, and what makes them unique is that they release the renin. So that's part of your renin, angiotensin, aldosterone system or mechanism, depending on the book. So the renin, aldosterone, angiotensin system or mechanism. And so renin is released from the kidneys. You have aldosterone released from the adrenal glands. You have the angiotensin released from the liver. Okay, so there's a lot of organs. You even have the lungs involved, right? The lungs release your ACE, right? Angiotensin converting enzyme. So kidneys, lungs, liver, adrenal glands. So a lot of cool things as far as organs that are involved in that whole RAAS system. Okay, so the granular cells release the renin. And these are, so your RAAS system is designed for blood pressure reasons. So it's to help us regulate the blood pressure. Okay, so there's the podocytes. The areas of, back to our colander analogy, they are what help with the filtration process. Okay, so your filtration membrane. So the podocytes, which is the cell, and some extensions of it, or gives rise to the pedicles. And these are very tiny, okay? And the reason why, knowing that the podocytes and the pedicles and all that come with it, the reason why it's important to know they're so tiny is because if your filtration holes are tiny, okay, large particles should not pass through. So that's why if you see large particles in the urine, in your urine analysis, that's not a good sign. Okay. Yeah, don't worry about this one. Okay, so you can sort of not worry about this page. We're going to talk about it in a second because it does have to do with filtration. Okay, so as things are filtering through, right, your macromolecules that get so-called stuck in the filtration membrane, okay, they can be, on one hand, they can be reabsorbed into your body. Okay, so molecules smaller than 3 nanometers will be allowed to pass, such as water, glucose, some amino acids, and nitrogenous waste, okay, and other toxins and other waste products. But then there's things that your body wants to keep, such as proteins, okay? So in other words, you will keep, well, let me see, there should be another. Okay, we'll jump to this one real quick. Okay, you want to keep water. It's a pretty good start. Okay, you're going to keep some ions, which are your charges, right? Your positive and negative charges, such as sodium chloride. Okay, you're going to keep blood. Okay, keep your proteins. Keep some water. Keep some ions. Okay. So if you find blood in the urine, proteins in the urine, glucose in the urine, too much electrolyte stuff in the urine, we know we're dealing with a problem. Okay. Okay. In the proximal convoluted tubule, okay, we have some pretty thin tissue, the simple cuboidal epithelium. Okay, and in the proximal, you're going to actually through the whole thing, the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. The whole reason for all that distance is to reabsorb some things and to get rid of things. Okay, so we'll start with, or that starts in the proximal convoluted tubule, the reabsorption and filtration process. Okay, the loop of Henle, the nephron loop, also known as loop of Henle. Sorry, that's the spelling. Loop of Henle. Okay, so this one does actually extend from the renal cortex into the medulla. Okay, so the proximal convoluted tubule and the distal convoluted tubule are found in the cortex, the renal cortex. Okay, but the loop of Henle does extend its way into the medulla of the kidney. Okay, the up part of loop of Henle is going to reabsorb sodium, the chloride and potassium. The down part is responsible for reabsorbing water. Okay, so as fluid is going through, there's a lot of stuff inside of the fluids. Okay, and with the proximal loop of Henle distal, okay, all that time of traveling, things are going to be pulled out and things are going to be sent into the tubes. Okay, so lots of water being pulled out on the descending part. Right, and as we go up, it's going to also be keeping some of the good stuff, some of the ions and those solutes we talked about a minute ago. Okay, antidiuretic hormone is at play here. Okay, keep in mind, in the presence of ADH, you keep fluid. Okay, in the presence of ADH, you keep fluid. Now, your body is constantly going back and forth on how much antidiuretic hormone is present in the kidneys. Okay, so if you had absolutely no ADH present, then you would be in diuretic mode, right? Which means you'd be losing a lot of fluid. Okay. So in the presence of ADH, you keep fluid, and that amount fluctuates throughout the day. And obviously, we need to have a little bit of urine, a little bit of fluid loss, so that the byproducts are expelled in a fluid environment. Okay, the distal convoluted tubule, which you find in the cortex, will get rid of potassium and hydrogens. Okay, so aldosterone, when aldosterone is present, you keep sodium and rid of, probably better said, some potassium. Okay, now obviously our body needs potassium, right? You have the sodium potassium pump. You have all these ions, all these electrolytes. Okay, we need magnesium and sodium, potassium, and so on. Okay, But also, if the amounts are too high, then in a way, no problem, your body will just pee it out. For example, if you take a multivitamin, and let's just say you took a bunch of it, okay, and kind of mega dosed yourself with a bunch of vitamins and minerals and all that, well, your body's going to keep some of it, but it's going to also pee some of it out, okay, because you can only retain so much of these things at one time. Okay, so the sodium chloride or table salt is being kept. Okay, so we can do our own version of diuretics. Okay, for example, alcohol is a diuretic. Also, that's one way we can get headaches from too much alcohol consumption is the decrease of the fluid, right? The decrease of water. And dehydration can cause headaches. Okay, caffeine is also a diuretic. Certain drugs for hypertension and edema can be a diuretic. Okay, pretty nice view overall, right? Starting with the Bowman's capsule. So hydrogens and some drugs, other books will actually use the word toxins. Okay, by the way, toxicology is a class that you take before you take pharmacology, right? Because the study of how the body processes toxins is important for either understanding the side effects of medication, if you're on that end of the healthcare spectrum, or creating the drug to be manufactured on purpose, so that, because when they make drugs, okay, like the biotech people and the engineers and the chemists and all that, when they make medications, they engineer them on purpose because they know the liver and the kidney are going to filter out part of that medication. Okay, so that's understanding toxicology, understanding how your body gets rid of toxins. Okay, once they understand that, then they can develop a medication to that they know the body is going to be processing that, but they also need enough to have it float around in your system to do its therapeutic effect, whatever that is. So when you see stuff like this, some drugs, that's ultimately what they're saying. Okay, that this is part of toxicology, part of how our kidney removes drugs and toxins and byproducts. Okay, NH4 is ammonia. So hydrogens, ammonia, toxins. Okay, and there's a bunch of things you could put under toxins. You know, anywhere from all the different environmental toxins to some of the byproducts and stuff you find in foods and things that you consume and drink. Okay, you know, medications and so on. Okay, so that kind of falls under the umbrella of toxins. So the arrows are showing that all that stuff, these byproducts, are left in the tubes, and then there are things that are brought out of the tubes. Okay, GFR, the glomerular filtration rate. Okay, and by the way, this is a lab that you can do on someone. You can measure their GFR, and this is something I do order quite a bit. In a way, this is almost standard when it comes with your what can be called a basic panel, okay, or a physical. Okay, so there's different facilities and all that call it different things, like basic panel or just a panel, okay, or a physical panel. Um, and there's kind of this, you could say, minimum standard blood test that you can do on people. And usually what that encompasses is thyroid, liver, like your liver enzymes, a CBC, metabolic panel. Um, your GFR, okay, glomerular filtration rate, and that might be it. Okay, and some of the fancier ones, they may add vitamin D, hemoglobin A1C, and C-reactive protein. Okay, these are always good to, if it's not included within the panel, these are really good ones to add. Hemoglobin A1C is letting you know if the person is flirting with diabetes or may have diabetes. Um, Vitamin D deficiency is very common. Vitamin D deficiency can cause a lot of problems. Okay, and C-reactive protein is good, is an inflammatory marker that lets you know if you have risk factors for cardiovascular heart disease. Okay, so if I see, or if anybody sees high C-reactive protein, that should be somewhat of a yellow or red flag to say, wow, we've got an inflammatory marker. And we also know when we see high levels of this, you could be on your pathway to cardiovascular disease. Okay. So GFR is part of this. And so they measure the rate at which that glomerulus will filter out the blood. Okay. So the volume of filtrate performed per minute by both kidneys is around 100 to 125 milliliters per minute. Okay. Okay, the goal of this filtration is to maintain homeostasis in your body. If you go back to our original simple concept of keeping the good stuff and get rid of the bad stuff, as long as your body can get rid of the bad stuff, you will maintain a level of, just to keep it simple, right? A level of purity in the body, low levels of, very low levels of things that can hurt you, such as the too much hydrogens and the ammonia and all that. Okay, so if GFR stops working, then what can happen is you can get high blood pressure because of it, increased toxins. Okay, so as fluid is coming into the kidneys, and there's some sort of a block, okay, the heart goes, oh, no problem. I'll just increase my pressure to push the fluid harder to go through the kidney. So that's one of the things that can happen when GFR is not working properly. So the filter, you can kind of look at it as the filter is clogged. So therefore, it takes more pressure to push the fluid through the kidneys. And the heart says, your basically your autonomic nervous system says, no problem. I'll just increase the pressure to push the fluid through the kidneys. Okay. So this is, as a bias of mine, this is one reason why when a person has high blood pressure, um, in my opinion, it's not because they're beta blocker deficient, right? It's not because they're medication deficient. There could be something going on. So I like to dive in deeper, and I can only dive in so deep. And then after I've exhausted my options, then send them to bigger guns, cardiologists and facilities that have fancier equipment and testing to figure things out. Okay. But I do think it's important to try to get to the underlying cause of why a person has high blood pressure. Okay. So if you have good GFR, then you'll have a good urine output and you'll have a lower blood pressure. Okay, this is mean arterial pressure. Okay, mean arterial pressure in the range of 80 to 180 millimeters of mercury. Remember, the millimeters of mercury is how we measure like blood pressure. So this is basically the average pressure in a patient's arteries during a cardiac cycle. Okay. All right, so this one is showing what can happen with increased resistance. So as fluid is trying to come in, if you take a big tube and make it smaller, okay, you've increased peripheral resistance. Okay, so if you have a lower blood pressure, chances are the afferent arterioles are open. Now, this one, to some degree, you have to be careful because changes in blood pressure are normal all day long. Okay. It has to do with, there's a variety of factors, how hydrated you are, to how much protein you have floating around in the blood, how long you've been sitting, how long you've been standing, exercising or not exercising, fluid intake, and so on, right? So your body is constantly changing and adapting to what we're experiencing within a 1 hour period, a 6 hour period, 12, 24 hour period, like all day long. So you're going to have changes. I've had people, like in my office, for example, they're sitting in the waiting room, they stand up and they walk into the exam room, and then they sit down, and then I take their blood pressure, and their blood pressure is really high. right? I'll get like, 190 over 90 reading. And I'm like, okay, what? And I tell them, and they go, well, I don't have a history of high blood pressure. It's like, okay. So let them sit there for a little bit, let the body reacclimate from standing to walking to sitting again, take the pressure or the reading a second time, and you see the pressure go down a little bit. Then we take it a third time, and you see the pressure go down a little bit. Okay. Now, in most people, their bodies can adapt pretty quickly to standing up, sitting down, and then things kind of stabilize. Well, sometimes people that takes a long time to adapt. Okay. And usually your seniors or, some people with pre-existing health conditions, like this person that I'm currently referencing, because they were a new patient, I found this, and they have a past history though of non-Hodgkin's lymphoma and hydrocephaly. Okay, so swelling in the brain basically. Also has osteoporosis, pretty bad. Okay, and then just some other health issues, and plus they're older; they're almost 70 years old. Okay, and uh, so and I took that into consideration. So you figure, they sat there for long enough, and you could take their blood pressure, but it for that person it wasn't long enough, so I had to wait even longer. So I'm just saying sometimes when you take someone's pressure, if their body is adapting very slowly, the blood vessels may take a long time to go from small to open or open to small. Okay. And there's, one kind of easy way you can test yourself is you get into like a catcher's position. So kind of that squatting catcher's position, and you stay there for a minute, and then just stand up really quick. Okay. Go from a catcher's position to just stand up completely erect quickly and see what happens. That is a massive change in pressure, and your body should be able to handle it. Okay. If it can't, you will know. And you'll be like, whoa, you kind of get a little dizzy, start to see the little spots, but hopefully your body will adapt within, 5 to 10 seconds or so. If it's really slow at adapting, you may pass out. Okay. So if you end up doing this test yourself, either make sure someone's there to catch you in case you do fall out, or if you're going to fall, like you land on a bunch of pads. So don't anybody like be passing out because like, I'm going to try this. Okay. And certainly don't do it on concrete or a wood floor. Okay. Kind of repetitive. All right. Okay. Our autonomic nervous system via the sympathetics, right? We're dealing with norepinephrine and then epinephrine. Okay, so, or epinephrine, norepinephrine. Okay, so in certain areas of your body, when epinephrine, norepinephrine hit the tissue, it will tell the tubes to go from open to more closed. So vasoconstriction. And this can increase your pressure, the blood pressure. Okay, so constriction of the afferent arterioles decrease the GFR, which increases blood volume and blood pressure. So in other words, when you're stressed, okay, by the way, stress is a very unique phenomenon. Wish we had time to talk more about it. I get into a little bit more detail in Pathophys with stress and stress response and what stress does to our body. But the super quick version is stress isn't good for you, especially chronic long-term stress. Okay, one of the things that happens is because certain tubes in your body can vasoconstrict, right? Anytime a tube gets really skinny like that or really small, the diameter gets really small, you end up increasing peripheral resistance. Okay, and so when you increase peripheral resistance, it usually what comes with that package is you increase in your fluid retention, okay, and then you increase the pressure. All right, um, some people are more stress resistant than others, and I would say not everyone really responds the same to stress. For example, when some people get stressed out, they turn pale, but other people don't. They can actually turn red, like the skin color. When some people are stressed, their skin breaks out in hives and rashes and things like that, and other people that does not happen. Some people, when they're stressed, their stomach and their digestive system lets them know. Pain in the GI system, unusual crackling and gurgling, very strange bowel movements, things like that. And other people, not much really happens. Okay. And some stress dramatically has them retain fluid and pressure, and other people, they don't really seem to retain that much fluid. Okay. But other things happen, right? So, in other words, stress hurts everyone, but people manifest it differently. Okay. Some people can't sleep when they're stressed. Some people, all they do is sleep when they're stressed. Some people cannot eat when they're stressed, and some people, all they do is eat when they're stressed. So stress has a variety of different uh, ways it can hurt you or exhibit signs and symptoms, but one of them can be the constriction of the afferent arterioles, or the tubes that go into the glomerulus. And when that happens, you increase blood volume and you increase pressure. Okay, the RAAS system is also there to increase your blood pressure. Now, keep in mind, if this is working in homeostasis, it's still part of normal. Okay, it can spin out of control, but typically the stimulus at the moment is low blood pressure, low blood volume. All right, and you are typically going to find those together. Okay, so in other words, if there's low blood pressure, chances are there's low blood volume. If there's high blood pressure, chances are there's also high blood volume, because they always tend to go together. Okay, so the RAAS system is activated, or when it's activated, you've got the aldosterone part that is going to keep sodium. And usually what accompanies keeping sodium is keeping water or keeping fluid. Those also typically go together. Retain sodium and you're going to retain fluid. Okay, so the kidneys release the renin. The liver releases the angiotensin. When renin and angiotensin and your ACE, which comes from the lungs, are all part of the formula that eventually produces angiotensin 2, okay, which is a vasoconstrictor, right, along with the adrenal gland, which releases aldosterone, okay, which will influence sodium and water retention. Okay, so that's kind of the quick version of your RAAS system. Vasoconstriction, retention of sodium and water. Now, when this happens, you're going to increase the blood pressure because the stimulus that caused this to begin with was geez, I wrote it down somewhere in there, but anyway, it was the stimulus was a drop in blood pressure, a drop in blood volume, and that activates your RAAS system. Okay. So a renal clearance test is used to detect GFR, and this can let you know if there's any glomerular damage. Usually this is done if they suspect renal disease or a person is on their way to that. There's different, which we talk more about that in pathophys when we get to different renal diseases and the different stages. And then at what point are you a candidate for dialysis? And then at what point are you a candidate for a kidney transplant? Okay, so there's different progressive stages to renal disease. And just for now, to keep it simple, there's the early stages, and then the mid stages, and then the late stages. And if they suspect that, you know, again, I'm a fan of labs, tests, images, such as CTs, ultrasounds, MRIs, X-rays, okay, because they reveal information. And if things come back positive, then it's going to depend on the degree of how positive they really are. So young person, not a lot of signs and symptoms, not really a family history of stuff, a little bit of GFR is out of range, okay. It may not be extremely high and serious, but it's worth investigating and seeing if we can turn this around. Okay, and you've got things working for you in this case. A young person, not a lot of signs and symptoms. The lab was just a little bit positive, not really a family history stuff. So you got things working for you. Versus someone who is older, a senior, a lot of pre-existing health conditions, comorbidity stuff, family history of different diseases such as renal disease, liver disease, heart disease. They're going to be more behind the curve, and that's a bigger fire to deal with. Okay. So either end of the spectrum, once you get a positive finding, it does warrant further investigation, and to the degree of treatment and to the degree of post-testing is to the degree of the severity of the case. Okay. So in my clinic, if we catch things that are just out of range, not a red flag, not creepy, not dangerous, we work on it right then and there. But if it starts to cross certain lines, then I refer out, okay, because we're getting into more complicated and serious territory. So the renal clearance test is a good test So the variables are the C part, which is the renal clearance rate, the U part, which is the concentration of the substances in the urine. Okay, the V is the flow rate of urine formation, and then the P is the concentration of the same substances found in plasma. Okay, now usually with this kind of stuff, the lab will, in a way, kind of do this for you. Okay, so it's just really nice to be able to order the test and let the technicians take over and give you the results. Now, there are some stuff that we can do that you can do, and we'll actually talk about later, like, for example, doing a urine analysis dipstick. Okay, and we'll talk about that in a bit. Inulin. Okay, so this is, it's a naturally occurring polysaccharide. Okay, you typically get this from plants. Okay, and there's just a way you can test for inulin clearance. Okay, so that's really all I want you to know from that is inulin comes from plants, and we can test for it. So it's called the inulin clearance. Okay, you can also test for penicillin clearance. Okay, so in other words, the kidney is responsible for the clearance of penicillin, and the clearance rate is pretty rapid. Okay, so this method would be used in like hospital situations. If they're interested in like the pharmacokinetics, the dose, when should they be given another round? Is their body actually handling it? Can their kidneys actually process this? In general, the penicillin can be cleared, I think, about 7 to 8 hours after consumption, after it's administered. Okay. With chronic renal disease, okay, typically they have to have a busted GFR for 3 months or longer. Okay, some of your risk factor people would be people with diabetes, people with hypertension. Okay, once you get into renal failure, the GFRs have a rate that is below 15 milliliters per minute. Okay. Uremia, which is raised levels of blood in, so increased blood. Of urea and nitrogen. Okay, this is where the blood urea nitrogen test would come into play. This is another lab you could do to assess people. Okay, blood urea nitrogen. Now, our body, if working properly, is pretty good at eliminating urea and nitrogen and other waste. However, if your filtration rate is very poor, these are going to become toxic. Well, they are toxic. What I mean is the accumulation is toxic to your body. But because they can't filter it out, they have to go under hemodialysis. Okay, and if things are bad enough, then they're on the transplant list. Okay, urine is can be clear to a pale yellow color. Urochrome is what gives it that color. So it's the pigment from hemoglobin breakdown. Okay, once you start to get into abnormal colors like a pink or dark pink, like a dark red or any kind of a reddish color, brown, smoky, or cloudy. Okay, these should be of concern. Also, foul smelling. Okay, now urine does have its own odor, but even with that kind of, we'll just say normal urine odor, you can tell if foul smelling. I mean, it's pretty gross. Okay, so that is just an indication that there is likely an infection or something else going on. In my world, in my clinic, I do UA testing, and we have them pee in a cup, and you just take this dipstick that can test for a bunch of different things that we'll talk about later. But one of the things that you are looking at is the appearance. Is the urine clear? Is it yellow, a deep yellow, a pink, a red, extremely cloudy? What's the odor like? Okay, now what alludes me to do a UA on someone, because they may be in there for neck pain and headaches. But part of the history is they'll tell you, yeah, I've also had some painful, like it hurts to pee. Okay. Or they'll say like, lately when I've been peeing, just my urine looks funny. It just doesn't look the same. It's got a darker color to it. So if they put anything like that on the table, we're doing a UA. Okay. And depending on the positive findings, depend on if we're sending them out or not. Okay, so odor, some of that comes from the ammonia. Okay, and also the influence of bacteria can change the odor. Granted, diet, so some of the foods that you eat, like your classic asparagus, can change the way urine smells. Also, coffee can do that. Okay, and just other foods. So sometimes it can just simply be coming from what you're consuming. Okay, you do want pH to be slightly acidic. I do test for pH. Okay, I think so. Some of the things I look for: specific gravity, and that'll let you know how dehydrated or hydrated they are. Okay, pH. Okay, one of the things about pH, if you're going to get an accurate test of pH, that needs to be tested within 1 minute after void, okay? Or as soon as possible, within just a couple minutes. Because the longer the urine sits there, the pH does change. So if you want to get a very accurate pH, you need to be testing that right away. Okay. And in functional medicine, we look at pH as an indicator if they have systemic alkalosis or systemic acidosis or metabolic alkalosis or metabolic acidosis. Okay, so those are important factors to consider for the person, because once you're getting into, like, let's say metabolic acidosis, that could lead to some pretty significant problems. Okay, and that stuff we also talk about in PathoFits. Okay, are they consuming an acidic diet? Are they consuming an alkaline diet? Can influence. Most people do consume an acidic diet, and I would say probably 99% of the time they don't know that they're consuming an acidic diet. And then here's the thing about that. Okay, on your ORAC scale, which is basically a nutrition scale that focuses on anti-cancer, what they will talk about and promote is a more alkaline diet. Another way of saying alkaline is basic, because cancer does not seem to do very well in an alkaline environment, but cancer does seem to thrive pretty well in an acidic environment. So, from a functional medicine perspective, as we try to visit with people on diet and lifestyle, there are many factors to take into consideration, right? Some of these we've talked about, like when we did the GI system, we talked about quite a bit of stuff. But another one is acidity. Okay, so I do want to know how acidic or not acidic a person is. And then all we do is just talk about it. Like, here's what they say. If your body is constantly in metabolic acidosis or systemic acidosis, then here's your risk factors. Like, here's what can happen down the road, such as cancer does like to thrive in an acidic environment. So there are some things that you can do that, let's just say, are that can resist cancer or anti-cancer. Now, we're human. This is life. Nothing is perfect, so it's not a guarantee, but it's better than the alternative, right? So, so in other words, practicing anti-cancer techniques such as increasing your immune system, lowering stress, increasing your antioxidants, okay, acid-base balance, okay, favoring the more neutral, so 0 to 14. 0 is very acidic. 14 is very alkaline or basic. Okay, 7 is neutral. So what we like to see people is somewhere between 6.5 and 7.5. Okay, so if we are getting scores of, say, 5.0, like, that's just not good in the long run. Okay, you're living in acidity, and we know that there are things that can happen to the human body that can be adverse health if you're too acidic for too long. Okay, and then one of the nutrition scales that can help you is the ORAC. There's a lot of information online about that. It just goes over the different foods that create acidity, the different foods that create alkalinity, different supplements that you can take to tap into the alkalinity. Okay, it's really good. On paper, very simple. It's very simple. Here's the foods we recommend you consume. Here's the foods we recommend you stay away from. Here's a couple of supplements. That's it. Right? Sounds easy, but then try to do it in real life. Okay? It's actually harder than it sounds. Okay, so some of the nitrogenous waste will be urea. Urea comes from amino acid breakdown. Okay, there's your blood urea nitrogen test that's used. Okay, usually the BUN and the GFR go together. Okay, you can also find uric acid. If uric acid is not being metabolized properly, you can get uric acid crystals, which is gout. So I do have some gout people that I'm helping, manage with their case. And of course, on my end, we're trying to do that through diet. Okay, because, I just tell them, look, if you're going to consume foods that have a very high risk factor for producing these uric acid crystals, let's stay away from them. Okay. And then we try to get other parts of their digestive components working better so that the body can actually metabolize and break down the uric acid in a more healthy fashion. Creatinine, okay, is a byproduct of creatinine phosphate, which is a byproduct of basically muscle metabolism. Okay. Some of the things you may see in a hospital, especially if a person is catheterized, is you may start to see the urine turn more of a pinkish reddish color, which means they may be experiencing a thing called rhabdomyolysis, which is an unusual breakdown of skeletal muscle. And a byproduct of that is high levels of creatinine found in the urine, along with some other components, why it's turning the urine red. If you see that, that should be a red flag. And this does happen to nurses, meaning the nurses are kind of the front lines people. Okay, they're kind of the ground troops that go in first, which means they see everything. They're the initial person of contact, and then their job, one of their jobs is to relay information if you suspect there's an issue going on. For example, you walk into a room, and for the first 2 days, the cath bag was fine, meaning kind of normal urine color. But then you walk in day 3, and you notice the urinary, the catheter bag is like, why is this red? When day 1 and 2 it was like normal urine color. Like, that should be a red flag. Okay, and since you're kind of the front lines people, you should pick up on that and relay that information to the doc on duty or whoever it is and say, hey, we've got something going on here. Here's what I found. Okay. And just as an example, that could mean perhaps rhabdomyolysis, abnormal skeletal muscle breakdown, which will give you elevated levels of creatinine phosphate, which will give you elevated levels of creatinine, which will spill into the urine. Okay, and then there's other things that you can find in the urine as well. So it's not unusual to find your ions, sodium and potassium and magnesium and bicarbonates and so forth. You're going to have trace amounts of these. And this is phosphoric acid, or a derivative of phosphoric acid. Okay, if you have abnormal high amounts, could indicate some sort of pathology. Okay, Let's take a 10-minute break. Okay, we'll come back and finish up and then try to get you out on time for lunch. All right, so we'll take a 10 and come back. Okay, the urinary tract, the ureters, the urinary bladder, and the urethra. Okay, so the ureters, which go from kidney to the urinary bladder, does have 3 layers: the mucosal layer, the muscularis layer, and the adventitia layer. Okay, so a lot of tubes in our body, your esophagus, your trachea, the large intestine, small intestine, and so on. A lot of tubes in our body have a mucosal lining. The mucosal lining, one of its functions is there to protect you, to protect the tissue. It is smooth muscle, so there is a peristaltic wave that does allow for the urine to work its way down into the urinary bladder. And then it has the outside adventitia, which kind of gives it a tougher outer layer. All right, you can see a picture here, an animation here of the mucosal layer. Okay, and then that middle muscle layer, and then the outer tough adventitia. Okay, the mucosal layer does have transitional epithelium. Okay, that would probably go back to ANP1, where you have the urinary bladder and the ureters, which have transitional epithelium, which means they're able to go in transition, right? They can move, and they kind of recess into themselves to allow more volume. Okay, the urinary bladder is to store temporary storage site for urine. Okay, you can see it right there, the urinary bladder. Okay, so we have the what's called the trigone area. Okay, it's a posterior inferior triangular area of the urinary bladder. Okay, there's the ureteral opening. Okay, so where the ureters come in. So the tube comes into that part of the bladder, and the urethral opening. Okay. So there's your trigone. Okay, the bladder has 4 layers to it, or 4 tunics. Okay, the mucosal layer, also made of transitional epithelium, has the ability to recess into itself. The rugae also allow for the distension, right? You also find rugae in the stomach. I think the AKA for that in the stomach is called gastric folds. But you can kind of look at the urinary bladder like this. I'm going to draw 2 of them. They're supposed to be the same size, so just pretend they're the same size. Okay, empty, meaning of urine. Okay, you've got this kind of this space right there. Okay, that space, this is what would fill with fluid. All right. So it does gradually start to fill with fluid. And then what happens is when it gets full, it would look like that. Okay, so there's more volume. And the ability to do that, so there's really not much change in actual size of the bladder itself. It's the inside components that change. Okay, so they kind of recess into themselves, and distend is the word. So what that does is it increases the volume. And at some point, when the stretch reflex is full enough, then you hit the neurological stretch receptors, and that gives you the urge to pee. Okay, and then what helps us control that is the smooth muscle and the sphincters. Okay, so the muscularis, you have the internal urethra sphincter muscle, and then you have the external urethral sphincter. Okay, the external is what we have some conscious control over. Okay, so if you, like, in other words, urine and all that is very autonomic. Your body just does it for you, stores it in the urinary bladder for you. But at some point, you can have some control over voiding or not. Okay, and that's where the sphincter comes in. Like, you can, in lay terms, hold your pee and you can wait. And then once you get to the bathroom, you can relax it. So there's where the void or micturating comes into play. Okay, so here is a empty bladder. Okay, a female urethra is, as far as length, is smaller, okay, than a male urethra. Excuse me. So if you've already catheterized someone, both genders, you'll have experienced, obviously, the difference in the technique. And if you haven't, you will down the road. Okay, and there is a difference in, which I'll teach you all that, just kind of the way the resistance that the cath tube feels as it's going through the ureter, and then once it enters inside the urinary bladder. Okay. In males, one of the things that males have to be worried about, especially when they get older, is the prostate. Okay, so the prostate, which is right here, does have an opening so that the urethra can travel through it. Okay, so when a male gets prostatitis, or inflammation of the prostate, it can create difficulty urinating, whether it's getting the flow started or just difficulty altogether. Kind of the follow-up pee, so to speak, may be off. Okay. So it's, if in the urinary world with females, as they get older, what can happen is they tend to, leak or pee, and just can come out. And then in males, it does the opposite. It kind of doesn't come out. Okay. So, your urologists and, there's other uh, professions, including professions that try to make devices to help with these situations. Um, but in general, women kind of leak and pee as they get older, and men kind of can't get it started. Okay, micturition, the fancy term for urination or voiding. Okay, so the autonomic nervous system is involved contracting the detrusor muscle, which is smooth muscle. Okay, so there's the muscle within the bladder wall. The nerves do come from the sacrum. Okay, which you'll actually see a video on that later. Okay, so all this that you're seeing here is actually going to be on a during lab time, a video. Okay. Any questions on any of this stuff before we break for lunch? Okay. Well, let's come back. Okay. So I have a video on this, the technique that you'll watch later, so I won't really get into all the technique stuff. But bottom line, you have the person pee in a cup, take a dipstick, and you measure it. Okay, and these dipsticks have special testing components to them for a chemical reaction, and they change color. And you line that color up with your legend. So all these testing kits come with like a color graph, and then whatever the color shows up, you record that. Okay, like for example, if there's blood in the urine, well, a normal finding, which means there's no blood, that part of the strip is white. Okay, if blood shows up, if it's just a little bit of blood, it kind of turns green freckled, and the darker, the deeper the green, the more blood is present. Okay, would be an example. Okay, on this, you do want to try to test the urine within 30 minutes after collection. Within that 1 to 2 minutes is best for pH. Okay, the longer the urine sits there, the more that will throw off the pH. Okay, the yellow color is because of urochrome. Okay, that's where the body breaks down hemoglobin. So the whole that whole process, and then you'll get some of that to spill in the urine. Okay, you'll be looking for the odor. So there is a certain ammonia-like smell to it. Diabetes can have more of a fruity or acetone-like smell. Okay, then you'll have another test on there called the specific gravity. And that your reference point is distilled water, okay, which is 1.000. Because 1 milliliter weighs 1 gram. Okay, so just water, distilled water doesn't really have a lot of components in it. There's not really a lot of things dissolved in it, like in distilled water. So with respect to fluid, it's relatively light, okay? So when you start adding chemicals and components and solutes and all that kind of stuff, you're adding things to water which will make it heavier. Okay, so the specific gravity, because of the solutes, can increase the score. Okay, like for example, 1.030 would be a or urine score. Um, High specific gravity, okay, usually means they're dehydrated, so limited fluid intake. I do a lot of UAs. I see specific gravity on most people is pretty high. And pretty much automatically, you can assume they're dehydrated, not getting enough water. And that's very common. A lot of people, especially in an arid environment like where we live, it's very dry here, which means we lose a lot of water to the environment and you don't even know it. I mean, think about it. You could go out and run on a day that's like 28% humidity and run, and you're like not even sweating. That's what it looks like anyway, because the water that's coming out of your body is immediately evaporating into your environment because there's not a lot of moisture in the air. If you go to a humid place, like let's say it's 100% humidity and you sweat, well, the water doesn't have anywhere to go, so it just stays on your body. So it's easy in an arid environment like Colorado to not consume enough good fluid, so you're dehydrated. Um, if there's an associated fever with high specific gravity, you can think kidney inflammation. Okay, that's called pyelonephritis. Okay, if they're dehydrated long enough, not enough fluid is getting circulated through the kidneys. You can develop kidney stones, also known as a renal caliculi. Okay, you can find ketones in the urine. So on that dipstick, it will have a spot on there to measure for ketones. Okay, if ketones are found, that's ketonuria. Usually it has to do with fat metabolism and excessive amounts. Okay, this can put a person in an acidotic state. Okay, there's a couple exceptions to ketonuria or ketosis, and one exception is they are on a ketone diet. I do counsel people on ketogenic diets. We do labs, we do UAs, we get into it, and we talk about, um, how to do it, what's going on, and so forth. Okay, so in fact, what I have people do is if they're gonna use me as their, um, let's just say, coach to help them with a ketogenic diet, then I want them to get ketone dipsticks. Okay. So, because I want them to measure, they pee in a cup and they take the dipstick, put it in, right? And it will turn a certain color if ketones are present. The deeper the color, the more ketones are present. Okay. If we're not measuring the urine, they could be doing all this work thinking they're in ketosis, but they're not. Okay. We also don't want to take ketosis too far. So that's why I like the testing. All right. Um, if they're not on a ketogenic diet, then there could be starvation reasons, okay, or just some other issues like diabetics, for example, can end up being in a ketogenic state, especially unmanaged diabetes. Okay, red blood cells should not be found in urine. A few exceptions to that. For example, if you're a runner, like an ultra marathon runner, they might have trace amounts of red blood cells in their urine because of the impact the feet and the body's taking over a long period of time. So, with some few exceptions of trace amounts, you should not find red blood cells in the urine. If you do, that's called hematuria, and it will show up on the dipstick, the urinalysis dipstick. Okay, so if you do find red blood cells present, it could be because of a urinary tract infection, kidney stones, um, or tumors, or some other issue. Now, menstrual cycles, you might find some trace amounts of blood in the urine as well. Okay, hemoglobin, if you do find it, hemoglobinuria, so the presence of hemoglobin in the urine, and the fragmentation or the breakdown, so hemolysis of red blood cells that causes the hemoglobin to be released into the plasma, it can go through the kidney and end up in the urine. Okay, so hemolytic anemias, transfusion reactions, burns, poisons, renal disease can cause that. Okay, nitrites. If you find nitrites in the urine, think bacterial infection, particularly E. coli. Okay, can also be early detection for bladder infection. So bile pigments or bilirubin. So if you find bilirubin in the urine, that's bilirubinuria. Okay, this can indicate liver disease or liver issues. And a good follow-up with this would be to do a liver panel. Okay, looking for your SGOT, your ALTs and so on. There's a bunch of liver enzymes. Those liver enzymes should remain in the liver. If they leak out into the blood stream, you'll pick up on that on a lab, and is basically an indicator that there's also something going on with the liver. Okay, so urobilinogen is also a marker that's on the test strip. Produced in the intestine from bilirubin, so it gives the feces the brown color. Okay, and some of the urobilinogen can be reabsorbed back into the bloodstream. Which, if that happens, it's either excreted back into the intestines by the liver or into the kidneys, which is released into the urine. So complete absence of urobilinogen may indicate renal disease or obstruction of bile flow in the liver. Increased level may indicate hepatitis, cirrhosis, or some sort of biliary disease. Okay, so these are definitely some labs that would warrant further investigation. In my time in practice, I have caught a few of these. It's very common for me to find, the specific gravity issues, the acidity. Sometimes I'll find, which we'll get into in a second, the white blood cells. But I don't really find a lot of the bilirubin and the urobilinogen stuff. Okay, that's not the norm for a clinic like mine. But from time to time, I do find it. Because once it gets to that point, we're dealing with a pretty significant red flag. Okay, so I'm definitely write my report and recommend they go see someone ASAP. And if they don't have anyone, then go to the hospital. Okay, because some people they just they don't have a primary care. They're kind of afraid to go. They don't want to put in the research to find one. Even if you give them a referral, they're likely not going to call. So then you can also just follow up and say, go to the hospital. Okay, white blood cells. Okay, so pyuria, presence of white blood cells in the urine. Okay, usually means inflammation, some sort of infection is happening. Okay, glucose. Okay, glucoseuria, if glucose is found in the urine, usually indicates that there's high sugar levels in your system. Okay, and if you find this, you are possibly dealing with diabetes. Okay, albumin, which is a protein, so the presence of albumin in the urine is not normal. Okay, albumin is the single most abundant blood protein, and it is very important for maintaining the osmotic pressure in the blood. Okay, albumin is large. It should not go through the glomerulus area. Okay, those podocytes and all that stuff we looked at earlier. Okay, your body should reabsorb that. So if you find it in the urine, then there's something going on. Okay, could be from poisons, heavy metals, bacteria, toxins, inflammation of the components inside the kidney, so glomerulonephritis, or hypertension. Okay. Then there's the microscope study of the urine. So you can take, a pipette and put a drop on your slide, put it under a microscope. Okay, and you can look for uric acid crystals, calcium oxalate crystals, cholesterol crystals, ammonium urate crystals, calcium phosphate, calcium carbonate crystals. You can look for epithelial cells, white blood cells, red blood cells, granular casts, hyaline casts. Okay, so tissue that should otherwise not be found in the urine, right? So think about the urinary bladder, the ureters, all that is made of a type of epithelium, right? And so if they're shedding because something's going on, I mean, that's not good. So they can look for that under a microscope. Okay. So my UA chart in Office looks very similar to this, right? You put the patient name, the date, time of collection, the person doing the ordering and the reading. So my name goes on there, patient name, date of birth, all that stuff. Okay. And then you just mark. So you look at the color, and in this, we're gonna make this up, pretending we're looking at a UA here. That's abnormal. So it's dark and it's cloudy. Okay. And the odor is foul. So that's the word I use when it is just awful. So foul. They had a pH of 5. Okay. Specific gravity of 1.03. We did not find glucose, but we did find the presence of albumin. Okay, we did find ketones, we did find red blood cells, and we did find leukocytes. Okay, let's say the rest were negative. Okay, so then now we have the report, and depending on the severity and your clinical experience, you can either work with them right then and there with a care plan, or you refer them out. Normally, I refer out because usually an infection is happening and I don't want it to get worse. Okay. So, like if I just see that the pH is like 5.0 and specific gravity is high, for example, then we'll work on stuff like right then and there, just begin a care plan. But if some of the other more serious things like leukocytes and you're finding blood in the urine, then that's likely dealing with an infection. So send them out to get fancier testing, get the kidneys and all that analyzed, and let the nephrologists and then perhaps infectious disease people or whoever take over and rule things in, rule things out. Okay, any questions on that so far? Okay. I want to do one more screen share with you. Well, never mind. My screen share is not going to work. So here's what I was going to show you. I was going to go to the module page, and so if you guys could hold on a second. So if you go to the modules page, you should see under week 9. Well, let me get it activated for you.